Welcome to the third chapter of OptiView's webinar series, How to Master OCT and OCTA. Today's discussion is being led by Dr. Greg Caldwell. Dr. Caldwell is in private group practice in Duncansville, Pennsylvania. In this presentation, he will explain how to utilize OCT angiography to detect abnormal retinal vessels in routine exams and expand patient care and practice revenue with an OCTA wellness program. We encourage you to type questions into the Q&A box, and Dr. Caldwell will answer them at the end of the presentation. Dr. Caldwell, please take it away.
Hey, thanks, Angela. And I want to take this moment to thank OptiView for giving me the opportunity to do this webinar. I truly hope that it helps enhance and increase patient care in your practice. All right, so tonight's program, how and why we brought OCT angiography into our practice, the transition from iView to the AngioView, how we use OCT angiography, the wellness side of it, and really the medical side, the diagnosis, treatment, and management. And really this is the highlights of our practice here. We're able to balance angio wellness with the medical treatment. You'll see here in the slide coming up that we have a really nice balance of a wellness program and a nice utilization for medical. Angioanalytics, this is a huge advantage in interpretation. We've had AngioView since it first came out, and I always say thought it was going to be Rocky Road ice cream, and then it turned out to be vanilla until Angiolytics came along. And you'll see that Angiolytics will actually give us quantitative numbers, percentages, and measurements, which really takes angiography to the next level and a huge advantage in our practice. And then at the end here, I'm going to show some tools, how our office has a 60% capture rate on these comprehensive eye exams. And then we'll have time, hopefully, I'm going to try and finish at about 40 minutes for some questions and answers. So here's our practice. The picture in the upper left-hand corner is a little bit outdated. We do have a fifth doc. We're proud to announce we have a new doc in our practice as of about 10 days. You can see we have about 18 to 20 staff. Private practice building there in that middle picture. We have 6 exam lanes. We're electronic health records. We have optical contact lens and a wide variety of instruments, including the angiography that we're going to be talking about tonight. In that lower corner down there, that's my son. I have to update that picture. He's just about as tall as me now, and he played golf tonight, and their team won, and he shot a 37. He was the medalist. A little proud dad there. All right, so where is our practice, my practice? It's in Duncansville, Pennsylvania. Right there is the star showing where Duncansville, Pennsylvania is. And really what I want to point out is we live in western central Pennsylvania where the annual income is $42,500. And that's important whenever you see the slide of how many patients in our area take advantage of our wellness program. So why did we bring angiography into our practice? First of all, it's always about the patient. And you'll see down there towards the bottom that there is additional benefits from cash flow and stability. But as anything, it's always about the patient. It enables a higher level of a comprehensive care. And this is really from the patient point of view and the medical community. I have primary care doctors saying, what do you have over there? What instrument? The diabetic patients are really now taking their diabetes serious. The retinologists with these occult membranes that we're finding. And they're excited that we're finding them, and we're able to get, sooner injections, anti-VEGF injections, Avastin, for the patients. So patient point of view, medical point of view, enhancing the practice and patient care is number one. It allows you to keep your patients longer. There were things that I might have referred out, and it allows us to keep the patient in the practice and manage them a little bit further, and we don't have to refer out. And again, I mentioned about the additional benefits of cash flow and stability that it brings to the practice, because it does not have to go to a third-party biller, especially with the wellness program. So here's our transition. For years we had the iView, and then we transitioned over to the AngioView OCT Angiography. I don't want to get too much down into the weeds on how these instruments work, but the iView scans at about 26,000 scans per second. So when the technician or a staff member is acquiring the image and they're saying to the patient, hold your eye still, hold your eye still, for every second that they're doing that, there's 26,000 scans. The AngioView and the Avanti platform, it jumps up to an amazing 70,000 scans per second. And with that, you start getting the wider views and the higher resolution, and really the ability to be able to do angiography. So that's why we moved up to the AngioView OCTA. The non-invasive angiography was what we wanted to bring to the practice. We saw some preliminary pictures, I guess, some of the studies being done, seen it, I saw it in lectures. And to be able to have one scan that enables visualization of the retinal vasculature to assess with a B scan was just, what we wanted to bring to our practice. Visualizing earlier signs of retina disease. I'm going to show you some really cool slides within angio wellness with diabetes and macular degeneration. Our traditional OCT was great for glaucoma, was great for diabetic changes in the B scan, awesome for that vitreoretinal interface. And traditional OCTs were pretty much meh for macular degeneration. Really, angiography brings macular degeneration right back into play, being able to find occult or see classic membranes, or to be able to see drusen that are suspicious and see that there's really no activity going on. And more importantly, where you think things are not suspicious, being able to pick up that choroidal neovascular membrane, or that net that's either in the retina or in the choroid. Angiolytics, which is trademarked there, you can see through OptiView. It's the only instrument that is able to measure the vessel densities and give a quantitative analysis, has really brought excitement into the practice and a high utilization, and bringing expertise to knowing what you're looking at with these patients, and then being able to follow these patients with progression, because you're able to measure the vessel densities within the retina. Well, early detection is another reason. We're picking up occult membranes. This is the retinologist called me the one day and said, after my second case that I sent over, which they decided not to inject and the patient bled, and they said, what do you have over there that you're able to pick this up so quick? They bled within about 6 or 8 weeks. And I explained to them OCTA, and they heard about it, knew about it, and they have about 6 or 8 offices. And plus they have to do fluoresceins because they own that instrument and can bill for it. At least that's my humble opinion on why they don't put OCTA in. But I think we're convincing them that this is a great technology. The OCTA and the Avanti platform gives you a wider field of view for the OCT scans, increased speed and efficacy. I mentioned about the 70,000 scans per second, which now increases the resolution, so it gives you the best image. OCTA expanded our wellness program. We were doing a wellness program, but adding the angiography definitely took it to the next level. And they had a great trade-up program at the time, so it just made it a no-brainer. And I just did a talk recently, and I know that those trade-up programs are still out there being pretty robust. So reach out to your local representative. So how do we use OCT angiography in our practice? Again, I mentioned earlier we have a great balance of wellness and medical. Obviously, our wellness program, because we see a lot of comprehensive exams with 5 docs in the practice with a 60% capture rate. We're doing a lot of wellness, but our medical is not a slouch either when we're following diabetes and macular degeneration and glaucoma patients, and we're billing out to the third-party payers out there. So, again, it's a great balance out there that we have within our practice of the wellness and the medical. And with that, you get to do webinars and try to spread to the colleagues, my colleagues out there, how to do this, because what I've learned over the years and over the different months of practicing, of lecturing and going to different cities and different areas of the country, is that I see my colleagues doing a really great medical OCT and they lack on the wellness side, or I see docs hitting it out of the park with the wellness, but then kind of dropping the ball on the medical side and really not really following those patients and taking advantage of maybe their scope of practice in their states. So for you that are out there on this webinar or listening to this webinar, maybe try and find that balance if that sounds like it's you in your practice, because it will definitely be a win-win for the practice and the patient. What I have here is a patient, a scan, an angio wellness report. It's a comprehensive eye exam, which we thought was relatively healthy. And then if you look at the left eye down there around the level of the RPE, you'll see a couple little lumps and bumps, which we were able to point out to the patient that, we'll just follow these over time. Certainly would not have been able to see that on a dilated fundus exam. The GCC looks normal, and then dropping down, and that's typically what we had with our regular wellness program when we had the eye view. We were able to do GCC and the B scan, but you can see down there at the very bottom, there's 5 boxes. The 2 at the very bottom on the outside left, outside right, that's your angio view. You can see there's 2 little yellow circles in there. That's giving you your foveal avascular zone. And what we're doing with that is really looking to see how round, make sure it's not oblong, and there is some numbers in that middle box there showing that there's excellent symmetry. And then the 2 color boxes, those are your vessel density, and there's numbers there, but those are not in microns, that's in percentages. And you can see the one on the right eye is a little bit bluer than the one on the left eye. We would maybe want to just make sure that this patient isn't a hypertensive or a patient with diabetes, or at least check out the quality of the scan to make sure everything's okay there. So this is just the patient that came in for a comprehensive eye exam, and they opted to have the Avanti Wellness with the angiogram with it. So you get a B scan, a GCC, and the angiogram there at the bottom. So here's a patient that came in that says, hey, I'm diabetic, and yes, I'd like to opt in and have this wellness. And if you just look at the B scans real quick, the B scans look good, GCC looks good. So I'm going to drop down to the very bottom where the angiogram is, and if you look at the bottom left, which is the right eye, you can see the foveal avascular zone is a little bit oblong, and that's what I have over here on the right side of the screen. And then if you look between the 2 yellow lines, I guess on the temporal side, you'll see a little dropout. And so this is a patient that comes in, and we would dilate them, see no dot hemorrhages, blot hemorrhages, exudates, so on and so forth, and we think that they were perfectly fine, and we're picking up diabetes and vascular changes at the highest level here that we can pick them up, and coaching the patient. And if you just look at that, I don't have access to a pointer on the webinar, but if you look at the retina picture that I have on the right-hand side of the screen, and if you just go outside that little, those 2 circles, go over to the right about a ½ an inch, and then up about a ½ an inch, there's a little bit of a dropout. There's capillary dropout, and if you see that, and if you look around this retina, you'll see other areas of capillary dropout. So this diabetes is a little bit more advanced with these microvascular changes. And this is the time when you'd have a discussion about the hemoglobin A1C with this patient, asking what there is, communicating it to their primary care doctor, and getting hopefully a good outcome by lowering the hemoglobin A1C for this patient. So here is a great wellness on a patient with diabetes. That's patient number 1. Patient number 2, again, the B scan looks great. The GCC is being flagged there in the focal loss volume. We would maybe check the pressures in that patient's eye and just make sure that there's no early signs of glaucoma. But if you look at the pictures which I have to the right, where the foveal avascular zone are basically copied and pasted and then blown up, you can see that they're not perfectly round. They're a little bit oblong. And the left eye is a little bit larger than the right eye. And you can tell that by looking at the numbers down there in the box. Again, in the middle, you can see where it says foveal avascular zone, kind of halfway down through that box that has a bunch of numbers in there. And it says area, millimeters squared, looks like 2.9 and 3.9. So there's about a 0.1 difference. Really, we've learned over the years you want to have a lot of symmetry between these eyes, and you can see there's starting to be some asymmetry, and that's happening because of the diabetes picking on the foveal avascular zone. Some studies out there and some docs are arguing that that could be one of the earliest signs where diabetic retinopathy shows up, is in that foveal avascular zone. So here's a patient here. Let's start off at the bottom looking at the foveal avascular zones. They look pretty good. We jump up to the ganglion cell complex. It looks great. But if you look at the B scan of the right eye, now the B scan is able to pick up the diabetes. So this is the most powerful, why we have this in our practice. It's very powerful in wellness. We are able to look at retina structure. This one here picks up the retina changes, and we look down into the angiogram. At least that's what's showing up here on this wellness report. We would maybe go and explore into the program by opening up the right retina angiography and scan around to see if we see any other vascular changes. But in this case, what picked up on the wellness was, hey, that B scan looks a little abnormal on that right eye right there in that macula area. And the left eye looks normal, but diabetes was picked up by doing a wellness report. And here we are. Here I am diving into this retina, angioretina, and you could see the abnormal vessels. If you just look at the angiography, again, this is non-invasive. This is done without any dye. And right where the green line and the red line cross over, you can see those abnormal blood vessels, and that's in the upper left-hand picture. If you jump over to the picture just to the right, you can see the different diabetic changes going on. And then if you go down into the B scan, you can certainly see the diabetic changes that are occurring that are a little bit more robust than the first two patients that I showed you. And we would definitely want to get this patient's hemoglobin A1C under control and work with the primary care doctor with this. And this would then generate, probably instead of a year follow-up, I'd sometimes say to the patients, yeah, we'll check you in 9 months or a year, and the patients typically say, doc, I don't feel a little comfortable with this now that I'm seeing that. Can I see that maybe in 3 or 6 months? I'm going to go and watch my glucose control, get my hemoglobin A1C, maybe exercise. Can I see if that helps pay off? So again, it's been enhancing patient care in the practice. One for the patient, as I mentioned, and then within the medical community, the primary care doc saying, "Doc, what do you got over there? You're getting these patients to get their sugars under control a little bit better." Here's a patient that came in just for a regular exam. The IOPs were 24. They opted to get the angio wellness. The B scans look good. The GCC looks good. But if you look at the vessel density, which are in percentages, let's look at the right eye first. And if you just look at the numbers where it says 47, 52, I'm looking at the right eye just going from top to bottom. I'm not going to do nasal and temporal. 47, 52, 49, 45. Down there around that 45. Look how nice, and a little bit of blue on the temporal area, which is expected. Nice and yellow and red down there inferiorly. If you jump over to the left eye now, 43, 51, 48, and then 40. That 40 is getting a little thin down there. That's where the ganglion cell complex sits. So this one here flagged me that I need to follow this patient a little bit closer. And it's with the angio, and you can look right above it, the GCC is not being flagged. So we might be catching the earliest signs of glaucoma with this patient based upon that 40 sitting down there and that vessel density. And you can kind of see how it's kind of forming how an arcuate would form. And just kind of keep that in mind, because I'm going to show you a couple glaucoma patients here a little bit later, and you'll see that that could be why I have some suspicion. And then this patient came in, and we found some drusen, and you can see the drusen up in the B scan. And the question is, are these causing any problems? And whenever we jump into looking at the retina angiogram, we can see that the drusen are not filling with any blood. There's nothing active. And again, we can follow this patient within our practice. We don't have to send it as a referral. We get them on the proper vitamin therapy, get them an Amsler grid, and follow them back in an appropriate time. So angio wellness is great in the practice. We use it again on the wellness side. It's great for medical. Again, diabetes, glaucoma, macular degeneration, and that list goes on. So I chatted in the first part there about the angio wellness. I'm going to move a little bit into a few cases here and how we use it. On the medical side, this is when you could bill now the 92132s, 92133s, and the 92134s. And again, here's a picture of a patient that in the past I would say, look, you have no diabetic retinopathy going on. And that's because we really didn't have a great way of looking at the vasculature. And we can see on these pictures just to the right of this fundus photo where it says eye with diabetic vascular complications, you can see how that foveolae vascular zone has expanded. Now, in the vessel density map, which is on top, that's what we used to have to try and look at and try and guess what was going on. In the scan down below, because we have angiolytics, you can see that it's able to measure that foveolae vascular zone. And you can see it's measuring at 0.443 square millimeters. And if you just look at the yellow circles there and just kind of follow that donut ring around, if you look right at 12 o'clock, you'll see a little bright white spot there. Nice little microaneurysm popping out, and then you have, as you go around that donut ring, you can see the black areas where there's actually capillary dropout. And if you go over to the other eye, that is kind of your normal. If you drop down to the bottom, you can see the foveolae vascular zone at 0.172 squared millimeters. So we're using it to follow patients with diabetes in the practice. Here's another one of my favorite slides, 2015, 16, and 17. You can see if you look at the B scans at the bottom, you can see in 2015 doesn't look like there's any in that inner retina, any dropout, any type of exudation or hemorrhaging. 2016, a little bit questionable. Maybe there's something happening, but by 2017, you can definitely tell on that bottom picture there, 2017, on that right side, you can see there's some shadowing going on from some type of exudate or hemorrhage that's in the retina. So it took until 2017 for it to show up on the B scan. But if you go up to the vessel density, and don't even have to even worry about looking at the numbers, you'll see the numbers of the percentages dropping. But you can see that as you go from 15 to 16, the blue lakes, which is showing dropout, and how expansive it had to be to even start showing some changes in the B scan. Again, another asset for following the diabetic patient in the practice. We're able to evaluate macular degeneration. This one here probably didn't need angiography in a sense, but it just kind of shows it off. If you're really good at interpreting B scans, you could see that in this picture on the left eye, on the upper image, there's a little hyperfluorescent right where that macula is. That hyperfluorescent gives a higher suspicion that there's a choroidal neovascular membrane. You drop down to the bottom picture, you see some fluid. It's really questionable. Should I send it? Should I not send it? And then when we shoot the angiography on this patient, and when I say shoot the angiography, remember, this is non-invasive, no dyes, dye-free. We just ask the technician, hey, can you get me a retina, 6.0, angiogram on this patient? And then we evaluate it. And if you look at the scan here on the left side, you're able to see the superficial plexus and then the deep, and then the third one over is the retina. That should be all black. You can see that choroidal neovascular membrane is sitting in the retina area, and when you look at the choroidal, you could see how well defined it is. And then if you still look at that same scan, the one that's on the left side, if you just go to that middle image on the left, you can see that activity of that blood right there, kind of in the middle, right where that little hump is. That's the choroidal neovascular membrane that has blood flow in it. If we jump over to the image over here on the right, right where the angiogram is, it's just I actually have a custom view where I'm trying to really just highlight the choroidal neovascular membrane, but that would be down there in the retina image where there shouldn't be any blood flowing through there. So we were able to get this patient over immediately to the retinologist to get their treatment. Here was a neat patient that came in. This was neovascularization of the disc. This patient is with diabetes. Long story short, he stopped his diabetic insulin medication to try to increase his blood sugar to help him put on weight. If you look at the right eye there, it looks pretty good, but if you look at the left eye, there's some hemorrhaging. Is there neovascularization going on? So I just asked my technician to get me an angiogram of the disc, and you can see on this, as we go to the middle two pictures here, you can see the nice florid neovascularization of the disc. I called up the retinologist, and I mentioned to the retinologist, I said, please, this patient stopped their diabetic medication in air because they thought it would put on weight because the sugar would stay in their body. Little did the patient know, and we all know out there that actually insulin, because it gets it out of the bloodstream, stores it in the fat cells, actually increases the weight. But the patient didn't know that. And their hemoglobin A1C went to 11. We had this long discussion. I got them to their PCP, their endocrinologist, and the retinologist just did an Avastin injection. There's another great picture there of the florid neovascularization of the disc. No question that was going on. Talked to the retinologist, and they just did an Avastin injection to help get rid of the neo. I asked them to consider not doing PRP, and after we all kind of worked as a team together, we all agreed that that was the best plan, and this patient did not have to have PRP, and they're lowering their hemoglobin A1C and not going to come off their insulin. But a really cool way to use angiography in the practice. I'm going to go through a glaucoma patient here. This was a 68-year-old woman with glaucoma who wanted a second opinion on her glaucoma treatment. She recently had cataract surgery with an eye stent on September 25th, 2017. She's currently still using dorzolamide 2% twice a day, Lumigan once a day in the left eye. After I worked her up and checked her pressures and did the dilation and the visual field and OCT and consulted with our surgeon that comes into our practice, we decided that the left eye, we'd go with a little bit more robust MIG surgery, so we did a Cahook dual blade along with her cataract surgery, and she's sitting currently in the right eye 12 without any medication and 16 with the dorzolamide and Lumigan. But let me show you, we were able to get her pachymetry readings by using the OCT in the practice. Traditionally here, we could see the ganglion cell and nerve fiber layer drop out. and you could see on the right eye the nerve fiber layer has dropped out inferior temporal, which matches beautifully over there with the ganglion cell being dropped out. On the left eye, we have superior and inferior nerve fiber layer loss in that superior temporal, inferior temporal. And then the inferior ganglion cell is dropped out. And we can see here that by looking at this traditional optic nerve head, nerve fiber layer GCC report, that the glaucoma is definitely worse in the left eye than the right eye. Visual field, again, shows that the left eye is more advanced. We could see that the visual field defect is a nice little superior arcuate, kind of matching that inferior GCC and nerve fiber layer loss. And it's also in the macula here, so we want to treat this one a little bit more aggressively and keep those pressures a little bit lower. And if we jump over to the right eye, you can see that there is a little bit of a nasal defect in the right eye. And again, the visual field supporting that the glaucoma is worse in the left eye than the right eye. So now how does it look on an angiogram, angiography, angiolytics? As you look at this, and again, I apologize, no pointer, there's a lot of information on here, but if we're going to look at the scan that's on the left, and if you go to the scan on the left and go down to the bottom where there's a nice kind of tie-dye optic nerve head, you can see this is nerve fiber layer, and you can see inferiorly how it's dropped out. But what's more exciting is if you go to the radial peripapillary capillary and the vessel density map, if you look at that little wedge that's dropped out, you can see that how that just matches the wedge defects that we see in the nerve fiber layer. And if you just keep going over, you can see that these numbers are the percentages. 49 and 48 is superior and inferior, but you can see down there in that inferior quadrant how it's being a little compromised from that little wedge defect. Now remember, that's the right eye. The left eye is worse. Let's go over and take a look at the left eye. The left eye, the nerve fiber layer, is more compromised here, superior and inferior. You can see that there's less tie-dye. You can see the numbers over here, how that's helping us out. But let's go over to the radial peripapillary vessel density. And we can see 41 and 36. And we can just see how that superior and inferior quadrant are definitely more compromised in the left eye than the right eye. And then just look at that nice wide blue wedge defect and how that is just showing that the glaucoma is worse on the left side than the right side. Now we have numbers, right? We're able to measure that. This is the beauty of angiolytics. I now have another way to check progression. I've had my angiolytics and angiography in the practice. It's September 25th. I'm kind of excited because within the next 4 to 6 weeks, we're going to have patients coming in that we're going to be able to run change analysis on for my glaucoma patients and follow them to see what's happening. Just like we do with GCC and nerve fiber layer, we're going to be able to do it with the optic nerve and the radial peripapillary capillaries. And check out these en face images. And the one I really want to highlight is if you just look at the left eye, which is that right scan, and just look at that inferior optic nerve, and look at those wedge defects that are showing up on this en face radial peripapillary capillaries. And then a lot of people don't realize that you do use the retina to be able to treat glaucoma. And the reason being, that's where the ganglion cell dropout occurs. This is that same lady. We know that it's worse in the left eye than the right eye. Let's look at the right eye first. Let's not look at the top 4 angiograms and the B scans. Let's go down to the bottom. And you can see again where the tie-dye colors is. You can see where the ganglion cell, that's a retina thickness map. And you can see where the damage and where the retina is thinned out. But if you just go to the left of that, you'll see where the vessel density is thinner there, that big blue lakes, and it just matches up And again, you're able to measure that, and that's going to be exciting whenever we're able to compare next year when she comes in as a progression to see how her vessel density is holding up. If we go over to the left eye, the same two, you can see that tie-dye map of that retinal thickness, you can see how it's more compromised than the right eye. And then you can see how that wedge defect just kind of comes right on over from where that came off of the radial peripapillary capillaries. And this is how we're able to show this to the patient. There's no measurements here, but this is really showing off to them how the capillaries are being damaged. It's that same patient. You can see that nice wedge defect coming off the inferior temporal of the optic nerve and the inferior temporal of the left eye, a little bit wider of a defect. So we covered angio wellness. We covered the medical side of it. Now, how do you pay for one of these things? Well, here's our 2018 numbers. I travel a lot. We had 4 docs in the practice. One of our docs is cutting back. So with that all being said, 4 docs equals 2.8 full-time equivalent optometrists. Now, we do have Optos in our practice. And with Optos and OCT Wellness, it's $50. Optos, OCT Wellness, and OCTA, $70. In 2018, as I mentioned, September 25th was whenever we added the OCTA. So we don't have a full year in, but you can see that we had 1,315 people do the Optos, and from September 25th to the end of the year, 984 were doing the Retina, OCTA, Optos, and the OCT Wellness. So with that all being said, we had a few people doing a standalone OptiView. We had a few standalone OCTAs. Our wellness program in 2018 generated $136,590. So that is our wellness program, and we do a pretty nice amount of medical in our practice. We don't send a lot of things out, and you can see glaucoma was leading the way with 406. We had retina at 353. Anterior segment, we use it a lot more for the scleral fittings, but obviously insurance doesn't pay for that. We had a few insurance companies pay for the 92132. Bottom line is we generated about $30,000 on the wellness. On the medical side. Wellness was $136,500 and $30,000 on the medical side. That totals $165,000 between 2.8, which is 4 optometrists in our practice, but full-time equivalent. So you divide that out. Basically, each optometrist in the practice is generating about $60,000 with using wellness and the medical. Now, I will throw a little asterisk out there. We do have Optos, wide field imaging built in with this, but really the anchor to our wellness program right now is our OCT angiography, as you can see here. So we're right on track for 2019. You can see January 1st, 2019 to July 31st. We have 1,656, which is 237 per month. And in 2018, we're averaging 197 per month. Again, that's about a 55 to 60% capture rate, depending on what month you look at. When I looked at this 1,656 numbers, that is patients getting a majority, the OptiMap, the B-scan, and the OCTA. So again, this wellness program, again, enhances patient care. That's number one. Elevates the practice from the patient point of view. Most of the time, the patients will say, you're not charging enough for this, but we'd rather have more people get it than not, because it really enhances and finds a lot of problems in the patient early. And again, it enhances us with the medical community, and it gives us that additional cash flow and stability to the practice that the cash is there instead of waiting for a third party to pay for it. So let's talk about some tools here on how to get this done. I'm not going to kid you guys out there that it all starts with the staff. This right there, as you can see in the picture, as the patient walks through the door, right behind that manila envelope, you can see there's the script. We have it circled in yellow so you can see. As soon as that patient walks through, every comprehensive eye exam gets offered this, and it's well scripted out. So again, it starts at the front desk. The staff needs to know the script, and here's our script. The doctor recommends that you have the OptiMap photos and the OCT done today. When combined, these images capture the surface and layers of the retina, which gives the doctor a complete picture of the health of your eye. During the exam, the doctor will review these images with you, carefully read over this form, check what you would like to have done today, sign and date the bottom. It's pretty much that simple. Very few times will the patient say, I want to talk to the doc. If they do, then the technicians are pretty much, hey, the doc's going to talk you into it. You might as well get it done because then we have to come back upstream here and try and get this done, and we have to go against patient flow. So again, front desk, technicians, usually the ones that get this done for the patient. Here are our two forms that we give. Here's the one where the office staff just says, please check which one you want. We offer still two levels. We offer the OptiMap and the Wellness OCT, and that's at the $50 level. And we offer the OptiMap and Wellness and OCTA at the $70 level. So there's the verbiage there. I'll be more than happy to share these documents with whoever wants them. And then the other document that's with it, you can see the wide field imaging, the normal OCT, and then we have the abnormal OCT. So between the staff, the script, these two documents, we're able to have a 55 to 60% capture rate. So, it benefits for the patient to have the staff explain. It's a complete image behind the eye. It's a larger view than the slit lamp. Quick. It takes minutes at most to acquire it. It's patient friendly. Again, non-invasive, no pain or drops required for these images. It becomes part of your medical record that will be compared to past images in looking for changes. And the best analogy that we use in the practice is, it's kind of like that driver's license. In Pennsylvania, we have to get a driver's license every 4 years. And every 4 years, I said, I don't change that much. And when I put those two driver's licenses from 4 years ago, I go, I did change. And that's the same type of technology that we're able to do. We're able to keep these stored and compare year after year and looking for those changes. And the patients really can grab and wrap their mind around that analogy. You don't have to have age-related disease for these photos, and they can be done and be found to be beneficial. And you don't always have to have signs or symptoms. Eye diseases can be asymptomatic. So really, I just have, I think, about a 30-second video here to show you. This is basically our staff presenting it to a patient. So I'm going to just play the video right here.
Hi, can I help you?
Hi, yes, my son and I are here for appointments.
Okay, I just have some paperwork for you. This goes over the tests the doctors want you to have done each year as part of your annual exam. These tests check for holes, tears, detachments, and potential diseases starting. Even if you're not having any problems at this time, it can serve as a baseline for future reference.
How long would this test take?
The tests only take about 3 minutes total.
And would we need drops?
No. In some cases, they will.
And again, that's our staff. Our staff does a great job answering the questions, talking to the patient. The staff has seen numerous times where this has identified different types of diseases. So really every single staff person is on board, which makes it really, really easy. So how to get started is, it really starts at the front desk with the staff and really good staff training. Here's a resource I want to point out. It's an OCT community. It's a private group. It's on Facebook. So for anyone that's out there that's on Facebook, just log on and type OCT space connect. The administrators of that are myself and Julie Rodman. Julie Rodman has written a book on OCT and OCT angiography. She and I are the administrators. It's a very friendly community. People post OCTs all the time for advice. So if you're looking for a resource out there, I just looked today. We're almost up to 2,300 docs that are in there. And a lot of people private message us from time to time. So that's a nice little community there to join if you're looking. If you even just want to go in and just read a lot of OCTs and get better, you don't even have to post. Just go through and scroll. We have lots of great cases in there. So in summary, expand patient care and private practice revenue with OCT angiography. The value of early detection of abnormal vessels in comprehensive exams, especially in patients with diabetes. You could use it in glaucoma or in ocular hypertensive patients. And really, angiography has folded back in that macular degeneration patient. I always kind of felt that really wasn't serving that patient to the highest level. Now I believe I flipped that, and I'm even doing more than a fluorescein angiography can do. Because remember, on occult membranes are below the RPE, and typically they're not leaking. And even if it's in the retina and not leaking, the fluorescein angiography will not pick it up because it has to be leaking. So really, OCT angiography in the macular degeneration patient has been wonderful. How to educate your staff and patients, that's really the key on what to do here for getting started in your practice. And using vascular imaging in diagnosis and treatment of ocular disease has just been a great asset for the patient care. So final thoughts, I can't say enough. OCT angiography enhances patient care, elevates the practice. You heard me say it. Point of view from the patient, medical community. It improves the referrals to specialists, and again improves that cash flow and stability. And here is a final picture of a choroidal neovascular membrane that was found with this instrument. So I have a few minutes here, I believe, to do some questions. So my final comment will be, keep in mind you can't do anything that we discussed tonight unless you have one of these instruments that can do angiography. So I'm just going to leave you with that final thought. And I'm going to open up the question and answer box here, and just give me a second or two to read through these, and we'll go with that. First question, how does OCT aid in the diagnosis of optic nerve head drusen plaquenil maculopathy? OCTA for plaquenil maculopathy isn't the best here for that. You would want to go to the B scan. The plaquenil maculopathy is more of a structural change rather than a vascular change. So this is one where I really can't tout up OCT angiography. It goes back to your traditional B scan. Now the OCT regarding drusen, you could see with how the drusen create compromise to the vasculature of that radial peripapillary capillaries, and then you can see how the nerve fiber layer is compromised. So that's question number one. Let me filter through here about another question. Do you use the Optos as a replacement for dilation? And the answer is no here. We do every single patient that we have. And I'll even fold in here and add to the question. We do not use wide field OCT to replace dilation. We don't use Optos to replace dilation. We dilate most patients. Sometimes they come in and they've had dilated last year. They haven't had any symptoms, so we don't have to dilate every year. But it does not replace dilation. All right. If Dr. C can share these with her, should I let her know we don't send a copy, but she can watch them on demand? Probably someone from OptiView will have to answer that one. Okay. Personally, I find OCTA to be well suited for retinal disease, diabetic retinopathy, retinal vein occlusion, and somewhat less so for the choroid, AMD, central serous. How meaningful have you found results in testing and in determining whether your patient may ultimately be treated for CMV? I think tonight, hopefully that answered your, I've answered that. This is where I have become a kid in a candy store. Finding these occult membranes before they turn classic. Remember, occult is below the RPE. The only way you could really see those with dye-based imaging would be to use ICG, because the fluorescein cannot see below the RPE, so you'd have to use ICG. And when's the last time you heard of a retinologist doing ICG? So from the occult membrane and macular degeneration, OCT angiography has been great. Now, central serous, it's going to show some leaky vessels that are out there. You're going to kind of use that along with the B scan to follow those patients. But where it comes in for central serous is for knowing for sure that there is not a choroidal neovascular membrane causing that. Question number 4 here. How do we differentiate between active and passive vessels? That's going to probably have to refer you to a different webinar. I'm sure Julie Rodman, I heard that I'm one of the 3rd series. I'm not sure what the first 2 series are, but I know Julie Rodman does a great job in showing passive and active vessels. I'm not sure if I can click back and find exactly where I want to be in one of these slides. But that's kind of, I guess, 201 and 301 interpretation of these images. That's where the blood flow measurement comes into play. That's where angiolytics becomes so important. And when there's no flow in those drusenoid type of patients, and when there's activity, that's where you'd want to kind of focus on. So probably just go to OptiView's Academy, which is online, and I'm sure that there's a great webinar or a great slide series on how to interpret the active and passive. You definitely need to have angiography to be able to do it, and then learning to interpret it, which, because we never had this technology before, there is a slight learning curve, but it's not that tough to be able to do. All right. We need some more questions that kind of roll in here. And I'll just wait to see it. That's the questions that I have so far. And I'll give it another second or two to see if anything rolls in. As we're seeing if any other questions roll in, I went back to this slide 21 here for this patient or this doc or the colleague out there that was asking about active or passive. If you look at this left-hand scan here, if you look at the top row, there's 4 images. You're looking at the superficial retina. There's no, and the deep, which is the second one over, there's no choroidal neovascular membrane. You're looking at the third over, which is retina, and then the choriocapillaris, which is the fourth. You can see the membrane. Now, the 2 images below, the image on the left is showing the blood flow activity. And if you look at that middle B scan, and you can see all the red on the left side there, That's the choriocapillaris. We expect blood flow to be there. Then you see it disappear, and then you kind of see it raise up into that hyperreflective cavity there. That hyperreflective cavity, when you see hyperreflective, that's a really strong indicator that that could be a choroidal neovascular membrane. And then right below it, you could see the blood activity. That's an active choroidal neovascular membrane. And if you just go right above to that third image over, you can see the red line and the green line is right through that area, and that's just depicting right where that choroidal neovascular membrane is. And then the image that's on the right side there, again, the red line and the green line going right through that choroidal neovascular membrane. You could see the scan down below with the angioanalytics, the red activity, the hyper-reflectivity, and that's how you can tell for the doc out there that had the question between an active and passive. And then if there's no activity, I believe I showed you one of those angiograms where we had some drusen, or the angio wellness scans where we had some drusen that the patients did not have any activity. And that's how you could tell. So right here is the angio wellness, the macular degeneration patient. As you scan across these B scans, you can see that there are drusenoid elevations. You can't really tell that there's any choroidal neovascular membrane just by looking at those. We go to the individual B scan, and if you look at this middle scan here below the superficial and deep, where those drusenoid changes are, you can see that there's no blood flow activity, so there's really no activity down there. Again, it's a little bit more higher advanced, getting to learn how to interpret them. A lot of great webinars out there by my colleagues. I would encourage you to take a look at those. Question rolled in, can signs of Alzheimer's be seen with an OCTA? The quick answer is yes. Duke recently put out an article that in dementia in Alzheimer's patients that there is a correlation, but in talking to all the colleagues out there, more work needs to be done. I know that I just recently have a primary care physician in the area. After hearing about the angiography that we have, he wins awards every year in the geriatric patient community. He treats a lot of dementia and Alzheimer's, and he's really excited about where this technology potentially can go in the future, where we as eye docs will be working as a team with them to, one, help make the diagnosis, and then once the treatment is started, to see if the treatment is helping. So the answer to that question is yes. It's in infancy stages. Please stay tuned. Well, here's some questions and now Ken rolling in. What do you typically go over with the patient on an OCT, and how much more chair time does it take with you? It takes probably about 3 or 4 minutes, I guess, extra with the patient. I'm going to skip back here. I usually start by, and I'll just kind of walk you through it. I'll click on the wellness button. The beautiful part of this is there's one button that you hit, it populates and pops up this image right here, all in one report. I can't tell you how important that is. I usually start in the middle. I'll go through my spiel here. As this is opening up, hopefully these numbers that pop up in the ganglion cell complex, if there's another scan along with your pressures for glaucoma, hopefully they're between 85 and 100. And I would say, well, voila, they are. That's great. We drop down here the focal loss volume. That's another test there of glaucoma. Very strong indicator. When it's yellow or red, we need to be able to investigate whether or not it's glaucoma. So I say that scale is right beside it. Green is normal, yellow is abnormal. So green is good, yellow is caution, red is bad. You can see all your numbers are in green, which translates to the 2 little green circles to either side of that box. Then I go over and I point out the other scale here that says, green is in the middle because it goes up here to these retina scans. The retina can swell, which would be yellow and red, and the retina can have atrophy, which would be blue. And then I quickly go to the outside scans and say, look, everything is in green. So we're good there. We go up and we look at the B scans, and I say down here where this white line is, this is where macular degeneration. We're looking at the retina, where diabetes, high blood pressure can occur, the vascular changes, and then we look at the vitreal interface where, floaters and PVDs, and as we all know, epiretinal membranes would occur. And then I drop down and then I look at the angiogram, quickly looking at the foveoavascular zone to make sure that it's symmetric. Look at the numbers there to see that there's a lot of symmetry going on, and then I look at the individual scans on the right side just to make sure that there's no dropout. Looking at the circles there, making sure that they're not oblong. And then I quickly look at the vessel density numbers. Again, a blessing having the numbers there. I've looked at these enough that the inner circle there should be around 46 to 53, and then high 40s, low 50s in that outer ring. And then it's always thicker nasally than temporal, as it's depicting there on both of those patients. So that's about as long as it takes to go over it with a patient, and obviously there's some questions on it. Is there any progression analysis for glaucoma angiography yet? I'm not sure. I'm going to probably have to turn that over to one of the reps or to one of the OptiView people to answer that. For the plain reason is the answer is going to be yes, but I haven't used it because my instrument is now just getting into the progression analysis because it's 1 year old. So the answer is yes, I just have not used it. And really, we're at 1 hour and 1 minute, and I think that was the last question that came in. So I'm going to actually stop there and turn it back over to Angela.
Great. Thank you, Dr. Caldwell. We would just like to mention to everyone watching this that you can see all of OptiView's other webinars on optometricmanagement.com/webinars/how to master OCT OCTA. And thank you for your time tonight.